Okay, well, we're a little bit after 12, so we'll go ahead and get started. Welcome to the third in our April Lunch and Learn series. We are joined today by Mandy Haugh. Did I say that right, Mandy?
It's how, but that's okay. No one
How?
says it right.
Well, I don't want to be one of those people. Mandy Howe from UW Health, and she's going to walk us through today's sexual assault examinations and the role of SANE nurses. Just a couple housekeeping things. If you have questions, please feel free to throw them in the chat. I'll be monitoring that for Mandy, and then at the end, we will have an evaluation. So it's really helpful for us if you fill that out. So we'll put that link in at the end. So without further ado, I will turn it over to you, Mandy.
Thank you. So like Nikki said, I'm Mandy Howe. I'm one of the ER nurses and SANE nurses at UW Health here in Rockford. I have to brag that in 7 days, I get to change some letters behind my last name. It'll be MSN, not BSN. So I'm so excited to share that with everybody. Got to celebrate all the wins. So I'll just get started. If it'll go. So our program, we are a full treatment facility, meaning we do the exam, we collect the evidence, we do all discharge planning, we administer all medications. Within our program, again, more bragging, we have 23 SANE nurses and 6 who are in training. Last year, we completed 146 medical forensic exams. So that's what the proper term for a rape kit is called with evidence collection. Those are for survivors, and we actually use the same kit for assailants. So I had one last year that was for an assailant. So far this year, we've completed 26, and that's as of April 1st of this year. More bragging, because we are very committed to our community. 3 of us SANE, so myself, Kimberly Wolgast, who's on, not to call her out, but and Katie Armato, we were sent to the Masters Summit on strangulation prevention in San Diego. This was a training hosted by the Alliance for Hope International and the Training Institute on Strangulation Prevention. Lots of us within our program, we sit on many different committees within the community. So some of you may know me from other committee work. Some of you may know Kim from other committee work. One that is more focused on sexual assault is the sexual assault response team. We're working on building that back up. So us from UW Health, we've got the Sheriff's Office, RPD, Mercy Health representatives, RSAC, the Family Peace Center, Merit, Carrie Lynn Center, representatives from the courthouse and Prairie Street Legal Services. So we all just work together to provide comprehensive and the best possible care that we can. And we branch out to domestic violence and child safety committees with the Family Violence Coordinating Council as well. So starting January 1st of 2023, the state passed a law that it is recommended and kind of required that all SANEs complete all medical forensic exams. The standard before was just any ER nurse or provider could do the medical forensic exam with evidence collection. And now the Attorney General really wants a SANE doing it. And I'll kind of go through why we are so special. But to become a SANE, you have to fill out an application with the Illinois Attorney General's office. The requirement is you have to be a nurse for at least a year prior. Then before the training, you have to do 16 hours of online training. Then it's the 40-hour didactic training. With COVID, it was kind of done online through Zoom, but now there's different trainings offered throughout the state that it's in person. Then after that, you have a clinical log to complete, which usually takes about 6 months to a year. with that, there's multiple medical forensic exams done with a mentor. So that's usually with an AA SANE or a SANE A. An AA SANE has completed the training and has not sat for the national board, which would then make them a SANE A. Within that clinical log, you're doing lots of physical assessments. Then there's extra training. So there's court time where you go and you watch expert witnesses, preferably another SANE. There's collaboration with RSAC. That's our advocacy center that we typically use in our area. There's training for forensic photography. A lot of times we work with the local police departments to have that requirement met. And there's a CDC training that's usually online. Same with the state crime lab training, which I think is wonderful. So we then can explain to our survivor what is done with their swabs and what the state kind of looks for based on our documentation. And then with all that, there's a mock exam with a certified SANE. So that's a SANE A. Or another option is a 2-day training with the Attorney General's office that you apply and then you travel. And either one is a really good option. It's just kind of like the last step to show you're competent in all the extra techniques that I'll go over a little bit later. So the first steps, a survivor usually either contacts RSAC saying they need services and they can kind of delve into, this is a new assault, old assault. If it's a new assault, then RSAC will encourage them to seek medical treatment. A law enforcement officer, sometimes they call 911, a law enforcement officer brings them in, or they just show up to us in the emergency department. When they arrive to us, we contact an RSAC advocate. So what they can do is they will bring a change of clothes, because sometimes with our evidence, we are collecting their clothing. They provide informational pamphlets on the survivor's rights and the services offered by RSAC. And they actually stay with the patient through the entire exam. One thing, they don't stay when the survivor is speaking with law enforcement, but otherwise they are there supporting them through everything else. Us, we're mandated reporters, so at some point we have to contact law enforcement, but if the survivor does not want us to contact law enforcement, we don't usually until after they leave, but we do have to report the crime. If they want to speak with law enforcement, then many times the law enforcement officer comes to the ER and they have their discussion. One thing to note, law enforcement officers, we don't allow them in the room when we are collecting the evidence. They usually will have that discussion either before or after the evidence is collected. For us, we immediately place them in a room. This is, safety planning starts immediately. So we put them in their own private exam room. If a SANE is not already there that can be assigned, we call one in. We triage the patient, and it's usually a pretty brief triage. We want everything pertinent to go in our medical forensic exam documentation that I'll go over in a little bit. We assign acuity 2, meaning they're a higher priority, and that SANE is one-on-one. So that SANE is there for just that patient. If one is working the floor, they give up their other patients and they are total care with that survivor. My supervisor, I have to brag about my cart. My supervisor got me a cart and we stocked it and labeled it, and I'm very proud of it. But our medical forensic evidence kit that has all of the swabs that we need, all of the documentation that we need, and we have extra supplies in our lovely bright green cart. Our camera is in our cart as well, and any extra testing supply. So if there's extra swabs that we need, speculum exam, or our speculums, our Foley catheters, our STI testing, so whether that be blood collection or swabs, it's all in our bright green lovely cart. For this, so all this paperwork that I'm going to go over is within the kit that is provided from the Illinois State Police. And for us, we are all about consent. With our process, we empower our survivors with every single choice. It is not all or nothing. It is completely up to them on what they want and what they don't want. Our job is, like I said, empowerment. We want to make sure they're healthy and we want to make sure they're safe. So again, we're all about consent. On this consent form, so the very first page, usually we can offer a full exam if the survivor presents within 7 days post-assault. I put our new consent forms that are starting to circulate on this presentation because the other ones will start fading out. One nice addition, if you look kind of in the middle of the page and then towards the bottom, there was the addition that gives the survivor empowerment and options that either they can contact law enforcement or law enforcement will contact them after their desired number of days. This wasn't done before, so I like it. It's a nice addition. With the new laws, so law enforcement has 10 business days to get our evidence when we are done with it to the state crime lab or whatever processing that, like DuPage County has their own crime lab, so they would get theirs to that crime lab. And all evidence is to be analyzed within 6 months. So before there wasn't really a deadline, now there is. So it's kind of nice that we can kind of get things going for our survivors. With this, the change with the new documentation, the survivor has to give us consent, and there's a part where they can initial that we can give the law enforcement officer a copy of everything within the kit. So before everything, a copy goes within the kit, and that doesn't really help the investigation. Then the detectives would get a copy of the documentation after the kit is processed. Now they can consent to have law enforcement have it right away. So that's kind of nice. If you look at the bottom part, it says hospital stop here. That is if the person doesn't want the evidence processed right away. So we can hold the evidence, meaning law enforcement holds it, not us at the hospital, but they can hold it and then they will either contact law enforcement and say, you know what, I want it processed now, and it gets put on the docket. Or another avenue is RSAC or whatever counseling service they're using. They can say, hey, I do want my evidence processed. So that bottom part is filled out when they make that choice. Otherwise, if they're under 18, it is held until their 28th birthday, or if they're 18 and older, we can, not we, but law enforcement can hold it for 10 years. After that, it is discarded in a private manner. I'm not exactly sure how, my imagination says it's some special incinerator. So this part, we kind of start getting into the documentation of the assault. So we confirm the patient information. We add the examination information. So usually the examiner is an AA SANE or a SANE A or someone. So then on a different part, there's like an assistant. That could be someone who's in training. We do have to put everyone who is present during evidence collection. So a lot of times that's the SANE. We list the patient. If there's an advocate, again, a lot of times it's RSAC. If they're present, sometimes if family members are present, we put them down as well. And then we start getting into the history of the assault. Again, law enforcement, we don't like them in when we are collecting evidence. Then we go to the narrative and the history. So this is where we just quote everything the survivor tells us about the event. It helps guide us to what evidence we want to collect and where we really want to highlight our specialized techniques that we can do as SANEs that I'll go over in a little bit. If we do have a warrant issued medical forensic exam, the documentation just states that evidence is collected per signed warrant. Patient assented, those kinds of things. They don't really tell us a description of what happened. This is a continuation from the history that they tell us. This allows for more details, and I like it because I feel like it helps. I don't want to say prompt, but it can help kind of a recall of the events, that if you say certain phrases like, did they touch you here? It might be, oh, you know what? I remember they did. I like to quote everything that is said. It's that way, like court time, it's exactly what the survivor had told us. It's not an interpretation, it is what was said. And again, this kind of helps guide our evidence collection. If you look, was there any part of the patient's body that was kissed, licked, sucked, or bitten? That can help guide us on where we want to swab or use our alternative light source, those kinds of things. This is more methods used by the assailant. This is another opportunity to where we can have quotes of what had happened. It can help prompt any recall for the memory. In traumatic events, there's fight, flight, freeze, and appease, and the brain tries to protect the survivor's mind, and the working memory just maybe isn't there. So this will kind of help guide the patient through recall. Post-assault, again, this kind of helps us guide our evidence collection. So if they urinated, defecated, if they've had a bath, if they've changed their clothes, maybe their clothes that they were wearing are still at their apartment or at their house or where they're staying. So law enforcement can go and collect those, and we don't necessarily have to collect the clothes that the patient came in with. The bottom part here, I'll explain more on the next slide, but that's the drug-facilitated sexual assault. Again, more guiding of evidence that we want to try to collect. And then the very bottom part is the underwear and clothing collection. So that's a lot of times, if it's right, the clothing that they were wearing during the assault or right after, we can still sometimes get evidence from that. So with the drug-facilitated sexual assault, again, we're all about consent. There's a consent form on this. So on the other previous slide, we do this consent form if there's a yes or unknown to any of these options. So loss of memory, loss of consciousness, nausea or vomiting, or drug or alcohol use. This is important to explain to the patient that with the drug and alcohol use, we are not looking to get them into trouble. This is to validate their ability to consent. If they were using drugs or alcohol and the state crime lab is able to test their urine to see, okay, well, at this point in time, this was your level, you would have been unconscious. It just validates that they couldn't consent. But again, we only do this if the survivor consents. So we try to get the first urine that we can post-assault. It is separate from our hospital testing. So with the consent form, they say if they want it tested, if they want it held, and this will go with the medical forensic exam kit with law enforcement to the state crime lab. Our hospital testing is just, yep, positive, negative. We don't get into the detail of the actual amount that is within the survivor system. So it's important to note that it is separate. So we do have separate urine samples. The first one we do try to have for the state crime lab. This is where we kind of start getting into our cool SANE techniques. So a SANE will do a head to toe exam. We start with the head and face because that's usually the least invasive. Our T-bars in the general exam, there's more explanation, but T-bars is tenderness, bruising, bites, abrasions, redness, and swelling. That's an acronym that is just well understood. So we're able to document if there's no injury noted, no tenderness or pain, we just do no T-bars. If there is pain, we use an appropriate pain scale, whether that be 0 to 10 or mild, moderate, severe. We do a description of observed trauma. So say they've got a bruise to their forehead. It would be a 2 by 2 centimeter purple circular bruise noted to patient's right forehead. If we collected swabs, if we've taken photos, the ALS is the alternative light source. So again, this is the cool SANE stuff that we get to do. We are like CSI. We do have the goggles and the flashlight, and we do look for highlighted anything. So that's usually bodily fluid, and we do that everywhere on the body. That's where that history comes into play, where we are able to, if the person says, well, they bit me here. So we put on our goggles, we hold up our special flashlight, turn off the lights, and we look. And we can note, okay, yep, there was positive ALS, swabs were collected, and that'll help guide us if there's any bodily fluid. If there was ejaculation done outside of the body, like on whatever body part, we can confirm that with that alternative light source. And we love our quotes. If it's bruise noted to right forehead, it can be he or she, the assailant, hit me with a lamp or something here, or punched me in the face with a closed fist. We're all about quoting what had happened because it really paints the picture of what the survivor went through. And it, again, guides our evidence collection. This is our body diagram. It's the same thing. We love our T-bars. Again, the pain scale description of what we see. So, a circular blue bruising noted to right upper shoulder, consistent with a bite mark. If we collected swabs, if we took photos, if we used an alternative light source, if it was positive or negative, and again, quote what happened. The assailant, if they know the name, bit me in my right shoulder. That way, again, we paint the picture of the injuries that we're seeing and what was reported by the survivor. Again, it's that head to toe. We do it all. This one a little graphic. It's the anogenital exam, but again, the SANEs do it all. We have that specialized techniques that we do. The TB dye and the Foley catheter I'll go over a little bit later, but we do an anogenital exam. If appropriate, we do a speculum exam. And when I say appropriate, if they're a teenage person who has never been through anything, or they are just so traumatized, we will defer the speculum exam. We can do blind swabs, and that's just for the DNA collection. We are there to empower. We are not there to traumatize. The entire process is very intimate and invasive, and we don't want to make it worse for the survivor to process what had happened. So again, this is all T-bars, pain, description of observed trauma, if we collected swabs, if we took photos. The ALS, if we use it, not all the time do we turn off the lights and when we're at this part of the exam, but some do, and we quote what occurred to be consistent with the injuries that we are seeing. This is the TB dye I was talking about. So this is really cool, and this is something very special to us SANEs that we get this training. So it is there to highlight injury that sometimes we can't see with our naked eye, even with a super bright flashlight. So the process is you swab, and a little bit goes a long way, but you swab with this blue swab, and then you take gauze with a lubricant and you wipe away. Anything that is left, it's either you overdid the painting with the swab, or it's a highlighted injury, and you can tell the difference. This is all done prior to the internal exam, just because a speculum can cause injury, and we want to make sure we are not the ones causing the injury that we see. The way I describe this to my survivors is I do my best to wipe it off, but it's going to look like you sat on a Smurf for a couple of days. But it's a really good tool. It's a great resource because it works. It does highlight those injuries that, again, we maybe can't see, or it expands an injury that we are able to see with our naked eye, with our big light. But maybe there's more to an abrasion that we're not able to see. This one is really cool. And that's what makes SANE so unique, that a Foley catheter, as nurses, we use, it goes into someone's bladder and it helps drain urine from their bladder. Well, us SANEs, we're crafty and we're MacGyvers. We insert it into a vagina and we overinflate the balloon, and it helps us look at the hymen. So the hymen is the tissue that surrounds the vaginal os, which is the tissue around the opening. So we inflate the balloon and we just look if there's notching. That is normal after estrogen's on board. Estrogen comes into play if they've had their period. And this isn't always done. If we've got those teenage people coming in, we're gonna limit the internal stuff. It's kind of what they are able to handle and what they consent to. If they don't want any of this, we don't do it. We offer it, but again, we're all about consent. So any notching, tearing, bruising, anything like that, we document just like a face of a clock. So straight up and down, that's 12 o'clock. If, 3 o'clock, 6 o'clock, 9 o'clock, or anything in between, it could be notch observed at 1 o'clock or abrasion noted to hymenal tissue from 4 to 6 o'clock. If it's bleeding, not bleeding, kind of what it looks like, we're able to grab that tissue with the Foley. So again, you put it in, you overinflate the balloon. I like to do 50 milliliters because it really grabs the tissue, and you just move it around and you're able to see as the tissue rests on that balloon, kind of what's going on. So not to get on a soapbox, but having an intact hymen is not a thing. So it doesn't matter to us. Everyone has a hymen. If it's intact, not a thing. This is just a way for us to assess the tissue. So more information. So all survivors are offered a shower after. If they don't want to shower at the hospital, that's totally fine. If they just want to go home, that's fine. But we do offer. If there's any further information about the medical forensic exam, we have extra space here to document that. In this extra space, we do document their demeanor, affect, any lab abnormalities, all of that. And then the middle part of this page is kind of our little checklist to make sure we've done everything. So if DCFS was notified, if the Department of Aging had to be notified, if there's a disability present and they're unable to self-report, this is kind of our way to make sure we are covering everything. Again, we're all about consent. We make sure we have consent and there's a signature. Consent for that toxicology that I was talking about with the drug facilitated sexual assault. And if police were notified. So this is if the patient doesn't want, if they want to, sometimes with our kits, they'll just come in, they want the evidence collected, they don't want anything reported, they just want it held, they just want to think about things. If they are not in that mental space to be able to go through doing the whole report and even considering the court process, we don't force them to do anything. This gives them that power to take control of their lives again. And again, this is that examining health professional. So it should be a AA SANE or SANE A, and that assisting health professional could be a nurse or a SANE that's in training. So for the demeanor, trauma impacts everyone differently. Kind of anything is normal, but the most common ones is they're crying, they're tearful, they're not able to be consoled, or they're flat and very stoic. Some process trauma is they laugh and they joke through the whole thing. Just a lot of times that's how they want to protect themselves. Or they're just physically tense, trembling, they fidget. And sometimes it's all of them. They go through all these different trauma responses within the exam on different parts. They go back and forth between different ones. It's all normal. So then when we're preparing for discharge, we kind of briefly talk about this before we start, especially before that anogenital exam, if we're doing certain tests. But again, we're all about consent. So they consent to whatever testing and treatment they do or don't want. So gonorrhea, chlamydia, that one, for us, we have a urine test that we can do, but if we're doing an anogenital exam, a lot of times we do the swab. If we need to do oral testing or anal testing, that's swabs. And then if they want medication, we do follow the latest recommendation of CDC guidelines that did change in 2021. So we do follow those, and those are reflected on the Illinois State Police paperwork here in front of us. Trichomonas is another one that we test for. That is swab or urine. We do swabs. Another thing that we test for, this is an educational point for us SANEs to provide to our survivors. We test for bacterial vaginosis and yeast. So if they present same day, if they're positive for any of this, they had it before the assault, because it does take time to present in someone. But we can explain that like yeast and BV, it's not an STI, it's the bacteria that lives on someone's skin is their normal flora. It just doesn't get along with the bacteria that lives on your skin that tries to keep you healthy, takes the opportunity to give you, again, yeast or BV. But that's something we test for, we can educate on, and we can treat. We do emergency contraception. So this is another one. If they're positive and they present, within those 7 days, it's likely not from the assault. We do need that negative pregnancy test before we do provide that emergency contraception. A lot of times we just do a urine, it's a point of care, 3 minutes, it's like a home test. We do offer an antiemetic called Zofran, or a lot of people are familiar with it, especially if you've had a kid. This is one that we encourage just because all of the medications can make you feel sick, and simply the stress of the entire process and processing what they had been through can make them feel nauseated. Tetanus we give to anyone as an infection prevention, especially if they're not up to date. A lot of times within the last 5 years, if they haven't had it, we'll offer it. Again, it's up to the patient. HIV is one with the high risk, low risk that we talk about. So if the assailant is an IV drug user or is sleeping with prostitutes, or they don't know them, that does put them in that higher risk category, and they have to present within that 72-hour period. After that 72-hour period, the treatment, the prophylactic, is just not as effective. Syphilis, that's another educational point. We test. This bottom part is, the HIV and the syphilis and the hepatitis, it's all blood work. So with that, we also test their overall wellness, but with syphilis, it's a blood test, and we don't offer the treatment unless it is a known documented positive assailant. It's just what the CDC recommends, and we follow that. For HIV, HPV, when we are doing our anogenital exam, we simply look for warts. We don't do the swab like for a pap test that an OBGYN does. We don't do that in the ER. We look for warts, and that's our testing. They can start the Gardasil series. It's a 3-shot series. They can start it with us, but a lot of times they choose to keep it consistent with whoever is managing their care after, which I'll go over in a little bit. Hepatitis B, that's one thing. Again, a blood test we can test. We can give them the booster, all of that stuff. Again, we follow the CDC guidelines. This is where I just had mentioned the follow-up care. Many times we send them to Crusader if they want to see their primary for the follow-up care in OBGYN or their county health department, we highly encourage the follow-up. It's just to make sure they're healthy. This way they're monitored for signs and symptoms and they can have that continued testing. The last sheet that I showed and this sheet, the survivor does get a copy of because it's a lot to try to remember. So it's that less than 1 week, if there's any positive, 1 to 2 weeks, and they should have follow-up care up to 6 months after. Then kind of the bottom part here, it's another checkbox to kind of make sure we're doing everything we're supposed to and giving the survivor all the resources that they need. So the medical forensic services fact sheet, they get that. They do get information on crime victim compensation. That is only if they report to law enforcement. And I've got a slide on that, so I won't go into that too much right now. They do get a voucher and that covers all outpatient services, and the ER is considered outpatient. So with that, I personally send a lot of people to Crusader or the health department just because I know that they take the voucher and that covers all out-of-pocket expenses to the survivor. And I have a slide on that in a little bit, so I'll get into more detail with that later. The after assault brochure and the hospital billing notice. So a survivor should not be billed for anything. So it'll go through their insurance and then any out of pocket is covered by the voucher, but it is illegal for us to bill them. And so we let them know that don't pay the bill, call our billing department. Cause yeah, they're not supposed to be billed. So they initial all those saying that they got them and we make sure we give it to them. And then they sign the bottom just saying that they received the paperwork and they understand it. So this is the voucher. Again, sexual assault survivors are not billed. That's Illinois state law. This voucher is provided to cover costs for the outpatient and follow-up care. It even covers medication. So say they need the HIV prophylaxis. That's expensive. This helps cover that. So it's to really help support the survivors through this difficult process. And it's something we do very well in our state. This is more information on that crime victim compensation. So they have to report to police and they can submit things to the state and words are hard. It'll reimburse the victims of violent crimes up to $45,000. This helps cover medical costs if they have to move, if they've had to take time off of work, either for therapy or injuries, surgeries, anything like that. If the crime occurred in their home and they needed to pay for crime scene cleanup, or if they needed anything replaced, they can submit all of that to the Attorney General's office. I always warn them, it is through the state, it's not immediate, it does take some time. But I always tell them, keep your receipts for everything. And RSAC can help with that. They're really good like that they help support everyone. So with our kits provided by the Illinois State Police, they have a unique identification number. So a K number. So it's K and then a series of numbers after. When we receive these kits from the state police, we log it in an inventory. And then as one gets used, we log onto this website, which is through the Illinois State Police Forensics tab. And we log the K number, what police department it went to, the survivor's, birth month and year, and it kind of helps keep track of everything. Something that's really cool is the survivor can actually log on to this and track their kit for up to a year. So it kind of lessens the anxiety of the process, that they can see, okay, so it's at the state crime lab, it's being processed. Oh, it's processed now. And that way they know, like, okay, so the detective that's investigating my crime should be receiving the report, or the state's attorney should be receiving my findings. So it's just another way to communicate and support the survivor that is really cool. There's different types of sexual assault, but no matter what the type is, it is never the victim's fault. So there's child sexual abuse, intimate partner sexual violence, where the perpetrator has some form of relationship with the victim, incest, that drug facilitated sexual assault that I had mentioned before, which impedes the ability for the survivor to provide consent. Stranger sexual assault is rarer than what is portrayed on the TV shows. But it is still an identified form of sexual assault. This list is not all inclusive. This is just kind of the more common and recognized ones. Discharge as nurses, you know, SANE nurses, we're still nurses. So we start our discharge planning once that person walks through our doors. And with that, safety planning is one thing that we start immediately. So with that, by putting them directly into an exam room, that helps keep them safe. We make sure that they feel safe leaving the emergency department, that they have a plan. You know, if they need shelter, we help secure that for them. If they are comfortable staying at a family's house, you know, we support them with that. If they feel better having law enforcement drive them home or to their family's house or to the shelter, wherever, we support them with that and we help make that happen. Our survivors who come to us, they always receive a follow-up call from RSAC if that's who came in. And then they receive a follow-up call from someone at UW Health. This way we can ensure that they have all of their needs met. It's usually not right away. Sometimes it's a couple days after. It gives them time to process. If they have questions, we can answer that, and it gives them the space to voice any concern that they have or a resource that they think they need that maybe we didn't see before they left or they didn't voice before they left. So it's a comprehensive support system that we just offer our survivors. For us, and required, but I can speak to UW's process, all of our medical forensic documentation, so all the papers that are within that kit that we get from the state police and any forensic photography that is done is in a separate part of their electronic health record. So it's hidden, it's password protected, only like 4 people have access to it in our health system. Not just anyone can see it. It's hidden. It's really cool. But it's the highest security. We keep it very, very private. So someone's primary care provider can't go in and look at the photos that we took or see the medical forensic exam documentation that we did. It's hidden. It's hidden well. This is my list of references where I kind of got all of my information from. And I want to thank you all for joining me. If anyone has any questions, just feel free to ask here, or here's my email if you don't want to ask here.
Thank you, Mandy. Does anybody have any questions? I don't see anything in the chat at this moment. Okay, I'm gonna put the evaluation in the chat right now as I meant. Oh, there is a question from Sherry. Can you talk a little bit about kits that are done for people when the time has passed quite a bit?
So for that, it's a conversation that we don't want to limit anyone, but it is a conversation of, I don't want to say, is it worth it? But it is a traumatizing and intimate process. And it's okay, after 7 days, if you've changed your clothes, you've showered, you know, the body is self-cleaning, we maybe won't have evidence. We won't say no, because again, we're all about empowerment, but it is that conversation that there likely is not going to be that evidence after that 7-day period. And honestly, it significantly drops after 24 hours. There are those unique cases where someone is kidnapped and they haven't showered or changed their clothes and they, those situations, yeah, we can probably get something at least from the clothing, but doing that internal exam after 7 days, again, we don't want to say no, but realistically, that evidence is just not going to be there. I hope that answers the question.
Follow-up question, can you please talk about working with kids? This is a person that works with a lot of kids that are coming out of abuse or neglect situations.
So for us, if they are 12 and under, we actually have a contract with Merit. So we will call Merit and they will come in and they will do the evidence collection. For us at UW Health, we are 13 and older is our training, and that's our treatment contract. Again, we try to support them with whatever they need. My presentation is for that 13 and older age group. For younger kids, we don't do the internal exam, we don't do a speculum, and honestly, in a lot of teenagers, we just don't do the speculum exam either. But there's consent and then there's assent. Like they have to want the evidence. We are not gonna hold a child down to collect any swabs. We don't want to traumatize anyone. It's whatever they are okay with. One thing that we do that I think is really cool is with the alternative light source, we have 2 sets of goggles. So the survivor can wear those goggles. And that's one way, the younger ones who are coming from that traumatic situation, it involves them. And again, more empowerment. It involves them. They get to see it. They're a part of the process. And hopefully it starts that process of closure. But sometimes it doesn't. They say it takes 2 sleeps, and those that are coming from those traumatic situations, they don't process it. It takes a long time, lots of counseling. So we just follow their lead, what they want. It's not all or nothing. It's really whatever they want and what they can tolerate.
Thanks. And that was a perfect plug for next week, Mandy, where we are going to be joined by Shannon Kruger, who's the director of Merit. And so she's going to talk about identifying and responding to child abuse. And I'm sure she'll touch on the forensic exams they do over at Merit as well. So if you're not signed up, you should sign up because we'll touch on that next week. Great. Any other questions? All right, well, Mandy's contact information is on the slides. Link for evaluation is in the chat. We thank all of you for your time. April is Sexual Assault Awareness Month, so support RSAC, support your local agencies and nurses that are doing work around this really difficult topic. So thank you, Mandy, and thank you to everybody else, and enjoy your afternoon.
Thanks, everyone.